Welcome to our fourth case study. Let's begin with the clinical presentation. We have a 64-year-old man of East Asian descent with no known significant medical or family history, presented in 2019 with a 12-month history of diarrhea, mild anemia, and weight loss. He had also experienced numbness and burning sensations in his hands and feet since 2017, initially interpreted as mild peripheral neuropathy without functional impairment. He denied weakness at that time and had a normal neurological examination. Initial workup, including fecal immunochemical testing, stool ova and parasites, abdominal CT scan, and EGD colonoscopy, was unremarkable. Random mucosal biopsies showed no specific pathology. Blood work revealed mild normocytic anemia, hemoglobin 127 to 132 grams per liter, but normal inflammatory markers and normal results for vitamin B12, HbA1c, thyroid function, renal and liver function, and serum urine protein electrophoresis. Nerve conduction studies NCS performed 2 years earlier were within normal limits. Cholesterol was trialed empirically, resulting in partial symptomatic improvement. By 2020, his symptoms progressed to include gait imbalance, orthostatic hypotension, bladder urgency, erectile dysfunction, and worsening paresthesia. He also reported new bilateral hand weakness affecting fine motor tasks. Laboratory workup revealed mild leukopenia, white blood cell count of 3.1 billion cells per liter. These evolving signs raised the suspicion of systemic disease and prompted referral to hematology. Diagnostic workup. Re-examination of prior duodenal biopsies using Congo red staining confirmed the presence of amyloid deposits. A bone marrow biopsy with Congo red staining also demonstrated amyloid deposition. Mass spectrometry performed on the Congo red positive tissues confirmed transthyretin type amyloid. Further evaluation ruled out plasma cell dyscrasia. Serum-free light chains and repeat SPEP-UPEP with immunofixation were normal. Neurological reassessment revealed intrinsic hand muscle atrophy, bilateral foot drop, and sensory loss extending proximally to the elbows and knees. Repeat NCS now showed severe sensorimotor axonal polyneuropathy consistent with amyloid neuropathy. Genetic testing revealed a Val30Met pathogenic variant in the ATTR gene, establishing the diagnosis of hereditary transthyretin amyloidosis. Cardiac involvement was suspected due to mildly increased left ventricular wall thickness observed on transthoracic echocardiogram (TTE), despite normal ejection fraction and absence of clinical heart failure. A technetium-99 M-pyrophosphate (PYP) nuclear scintigraphy scan demonstrated increased myocardial uptake, confirming cardiac ATTR deposition. Timeline of clinical course. The chronological development of symptoms, diagnostic evaluations, and treatment initiation is summarized in this figure. Here's a simplified visual timeline of the patient's disease course. 2017. The patient, a 64-year-old East Asian male, first reported tingling in his hands and feet. Early signs of peripheral neuropathy. 2019. He developed persistent diarrhea, anemia, and weight loss, prompting referral to internal medicine. 2020. Symptoms progressed to include gait imbalance, orthostatic hypotension, and mild leukopenia, suggesting autonomic involvement. In October 2020, previously negative endoscopy biopsies were re-reviewed and found positive for amyloid. November 2020. Mass spectrometry revealed Val30Met mutation consistent with hereditary TTR amyloidosis, and PYP scan was positive for cardiac uptake. January 2021. Nerve conduction studies confirmed polyneuropathy, and the patient was started on RNA interference therapy. Treatment and outcome. The patient was initiated on patisiran, a small interfering RNA, siRNA therapeutic, in January 2021. Patisiran targets hepatic production of both mutant and wild-type transthyretin, TTR, thereby reducing the substrate available for amyloid fibril formation and slowing disease progression. At a 9-month follow-up, the patient reported subjective stabilization of previously progressive symptoms, including numbness, weakness, and weight loss. Neurological examination demonstrated mild improvement in distal motor strength in both the upper and lower extremities. Importantly, repeat nerve conduction studies (NCS) showed no further deterioration compared to baseline, indicating disease stabilization. No adverse effects related to treatment were reported. Despite persistently abnormal values across multiple parameters, the relative stability or slight improvement in select measurements is consistent with therapeutic benefit, especially given the progressive nature of untreated hATTR neuropathy. This case illustrates the complexity of diagnosing hATTR, especially when symptoms are predominantly gastrointestinal and neuropathic, and in the absence of a definitive family history. A high index of suspicion is essential in evaluating adults with unexplained neuropathy, GI dysfunction, and mild hematologic abnormalities. Early use of tissue staining, genetic testing, and nuclear imaging can expedite diagnosis and facilitate early therapeutic intervention. Timely treatment may stabilize or improve neurologic function and prevent irreversible organ damage.